This lecture is for about 35 minutes to 40 minutes. I will try to reduce because you are all very hungry. And whenever we are going to evaluate ankle joint, we have to look tendons, ligaments, inflammatory conditions, neural abnormalities, bone abnormalities, and other conditions like fractures, osteonecrosis, tumors, diabetic foot, bone marrow changes, syndromes. This is FOV should be less than 140, 3 millimeter or less than that. We can use FS or without FS. Stir sequences also must to see the bone marrow edema. And this is axial. It should start from soleus insertion below the foot. You can see the sole of foot. And coronal from lateral malleolus to medial malleolus along the tibial talar joint. And coronal you can see from anterior to posterior, at least tarso-metatarsal to posterior respect of the Achilles. So this is how we will do it. And at least one stir I will include always to see the bone marrow edema, and T1 without fat sat by seeing the muscle fat infiltrate, because it is normal or fat infiltrated or denervated. So always I will use one T1 without sat, either in sag or coronal or both together. It will be taking additional 1.5 minutes extra. So this is very much essential. So T1 is also very important. Coming to tendons. Wherever you go musculoskeletal, it is anatomy. If you are thorough in anatomy, we can do wonders. The tendons are divided into 4 categories. This posteriorly, what we are saying is the tendoachilles, and this is the tendoachilles, and this is the soleus, and the small plantaris over here. So there are 3 tendons posteriorly. And if you are going medially, here also 3, you can see the tibialis posterior, and you can see the FDL. You can see the FDL over here, and this is the FHL. You can see the FHL. FHL will have large muscle belly. So TP, FDL, FHL. This is posterior. And laterally, you can see the boomerang shaped. We can see the boomerang shaped brevis, peroneus brevis, and you can see the peroneus longus. Brevis means it is close to bone. It is B to B, close to bone. And it is boomerang shaped. Anteriorly, there are 3 things. You can see the tibialis anterior, and you can see the EHL, and you can see the EDL. Sometimes we may get peroneus tertius also. You can see there are 4 anteriorly. So anterior compartment, posterior compartment, medial compartment, lateral compartment. This is how we are dividing the ankle joint tendons. We will start with the Achilles. Achilles is the one longest and strongest tendon in the body. The anteroposterior diameter is 7 millimeter, transverse diameter is 13 millimeter. There are 3 important structures forming the Achilles: gastrocnemius, soleus, and plantaris. There is no synovial sheath. It is very much essential. We should not report Achilles tenosynovitis. Only it is paratinon, it is paratenoitis. That is very much one we should always keep. There is no synovial sheath for Achilles tendon. Please don't mention tenosynovitis of the Achilles tendon. And bursa, there are 2 types of bursa. Anterior slopes, but it is retrocalcaneal, retroachilles bursa. The anterior surface of the Achilles should be always concave. That is one thing we should always look. And this is the coronal image. Beautifully you can see the 3 areas. You can see the insertional site. This is called as insertional site. And what you are seeing is the rest of the tendon. And from 5 centimeter, this is called as watershed zone. And the myotendinous junction, where you are seeing is the soleus attachment site. Usual length is 12 centimeters. So these are the things always carefully look. This is the sagittal image, and this is the coronal image. What you are seeing is the coronal image, how it is inserted. Axial, which I told already, the anterior surface. This is the anterior surface, which is concave. You can see it is the, I think the marker is not working properly now. Up to now it is, so I will try to show it with the arrow itself. And you can see the anterior surface will be by, you can see the concave. This is very much important. This is soleus, this is the plantaris. And you can see the attachment site of tendoachilles, and this is the plantaris attachment site, which is very small. And whenever it is going for abnormal, there are conditions like congenital or disorders like cerebroxanthomatosis. Cerebrotendinous xanthomatosis is nothing but lipid storage disorder because of defect in activity of the hepatic mitochondrial enzyme sterol 27 hydroxylase, where lipid will be deposited in some of the areas, especially tendons are deposited. Cerebellum, basal ganglia, thalami, spinal cord, and you can see the tender achilles is replaced by low signal. You can see the xanthomas. It is very classically seen as how much it is instead of, you can see how much deposited over here. Same thing, cerebellar deposits will go for signal changes, and spinal cord deposits, you can see the bright signals in the lateral as well as anterior as well as posterior column. This is the classical case of cerebrotendinous xanthomatosis. So whenever you are seeing bilateral symmetrical enlarged tender Achilles in a non-traumatic patient from congenital, it is a very important thing we should keep in our mind. Coming to tear, it may be partial or full thickness tear. Partial thickness tear always intrasubstance, invariably intrasubstance, or it may be of insertion site. You can see the intrasubstance, instead of becoming concave, it will become convex, and intrasubstance bright signals have come, and this is the classical retrocalcaneal bursitis. This is partial thickness tear, and you can see the very large partial thickness tear with the bicon. You can see that it is become rounded or ovoid shaped with the intrasubstance bright signals, and classical footprint avulsion. You can see the footprint or insertional site avulsion injury with marrow changes. This is one among the part and parcel of Haglund lesion. That means footprint tendinosis, tear, proliferation of the postero-superior calcaneum, retrocalcaneal bursitis, and retroachilles bursitis. This is very classical appearance of Haglund lesion. And footprint full thickness injury, you can see the footprint full thickness injury, it has gone back, and when it is very severe, you can see how much it has migrated superiorly. To identify the acute or chronicity, apart seeing from the fluid collection, signal changes, sometimes this ossification, myositis ossifications or calcification can occur in the retracted tendon. This is one thing which will tell is it acute or chronic, or acute on chronic one, all these things. It is a classical cut injury at, it is watershed zone, 5 centimeter above the classical cut injury commonly occurring. It is acute cut injury of the 5 centimeter from the watershed zone, and this is a chronic cut injury. Whenever there is chronic cut injury, the end will become more bulbous nature. You can see the bulbous nature and the fluid collection. This is a classical case of chronic cut injury, where you can see the bulbous end gone for degeneration. In these cases, going back and stitching is not much useful. The graft is very important. That's why the importance we have to mention in our report, it is essential. And this is a classical myotendinous junction or soleus tendon insertion site. There are 6 types of injuries we have to describe. Is it footprint, or is it partial thickness, or is it at watershed zone, or is it myotendinous junction? All these things we have to mention in our report. Soleus tear, usually it will occur a little bit higher position. You can see it in the leg areas. There are soleus tear and bright signals within the soleus muscle. Haglund lesion, which I have described, it is insertional Achilles tendinopathy with the tear and postero-superior calcaneal spur, retrocalcaneal retroachilles bursitis. Classical marrow proliferation and enlargement, retrocalcaneal retroachilles bursitis, insertional site degeneration with partial thickness tear. They are all very classical features of Haglund lesion. And you can see the CT beautifully demonstrating how it is proliferated. Commonly seen in young girls, those who are using high heels, that is also more going to suffer these things, or very especially elderly individual, weekend warriors, they are going for long-term run, marathons, all these things, they will suffer this. Coming to lateral tendon, we have completed the posterior tendon, lateral tendon. 2 important structures, peroneus longus and brevis. Here anatomy is very much essential. I am going down step by step. You can able to see the boomerang shaped anteriorly. This is the peroneus brevis, peroneus longus. It is encircled by superior peroneal retinaculum. You can see which is keeping in place behind the lateral malleolus by one important retinaculum. This is called the superior peroneal retinaculum. And by how to remember this tendons, this is bone, close to bone, B for B. So peroneus brevis will be close to bone, and it is boomerang shaped or linear shape. So it is peroneus brevis, peroneus longus, and you can see the superior peroneal retinaculum. So I am going down, and you can see how nicely it is placed and kept in sight by the superior peroneal retinaculum. I am going down inferiorly. And here one important structure, this is along the side of calcaneum. There are 2 important bony landmarks. This is retrotrochlear eminence. You can see the retrotrochlear eminence. Other one is peroneal tubercle, and this is peroneus longus and brevis. Here it is supported by inferior peroneal retinaculum. So this area is also very important. We have to carefully look. So 2 bony eminences, retrotrochlear eminence, peroneal tubercle, and this is peroneus longus and peroneus brevis, and this is a deep peroneal retinaculum. What we see, the first one is superior peroneal retinaculum, this is inferior peroneal retinaculum. Then we have to carefully look where this peroneus brevis is going. Peroneus brevis is going anteriorly, and you can see nicely it is going and attached with the base of fifth metatarsal. So this is the attachment site of peroneus brevis. And what is happening to the peroneus longus? We have to carefully see this. Peroneus longus is, you can see here, this is peroneus longus going, and it is traversing beneath the cuboid. This is called the cuboid tunnel, and it is going and inserting into the base of first metatarsal. So these are the things we should carefully. So peroneus brevis means it is fifth, peroneus longus means it is first, and cuboid tunnel crossing is one important area because cuboid tunnel syndrome can occur over here. This is concerned with the lateral tendons. This is sagittal image, this is the lateral malleolus, and the lateral malleolus, if we are seeing, this is the first one. You can see the peroneus brevis, and you can see the peroneus brevis and inserting over the, this is the fifth metatarsal base. And peroneus longus, you can see the peroneus longus traversing behind the cuboid tunnel, and it is nicely traversing, and you can see how beautifully going and inserting over it. So these are the things in the sagittal images. And what are the things can occur with abnormal tendons? Abnormal tendon, you can see the peroneal retinaculum has ruptured, so the tendon is started subluxating. Apart from that, there is intratendinous tear with tenosynovitis. Same thing happening over the opposite side also. You can see the superior peroneal retinaculum rupture with the longest tendon tear and tenosynovitis. And you can see that here also a severe form of a partial tear with the tenosynovitis of the peroneus longus. And you can see the typical appearance of both peroneus longus and brevis. Both they have gone for tear with tenosynovitis changes. And especially when we are dealing with rheumatoid arthritis, the bone marrow changes, and you can see the bony ossifications as well as projections. You can see it is producing compression effect over the peroneus longus and brevis tendon. Again, the lateral malleolus going for tear with tenosynovitis. So these are the things we should look. And one important syndrome is called as POP syndrome. What is this POP syndrome? Painful os peroneus syndrome. This can come along the lateral surface of calcaneum behind the cuboid tunnel. These are the sites we have to look. This is which we read. There are two important bony landmarks. This is the retrotrochlear eminence, and this is peroneal tubercle. So whenever it is becoming more and more large, they will go for continuous mass effect as well as irritation changes over the peroneus longus and brevis. They will go for partial tear with tenosynovitis. This is one among the cause for POP syndrome. Other one is os peroneus. There is a small bony projection will come adjacent to the tibial. This is a cuboid tunnel, and it will produce continuous irritation, and you can see the signal changes. So these are the sites where we have to look for POP syndrome, painful os peroneus syndrome. So we have completed lateral tendon. Coming to medial tendon, there are three important tendons: TP, FDL, FHL. FHL will have large belly. This is classically what we have to look. If you are going down normal anatomy, you can see the TP beautifully going down, and it is insertion over the, but you can see the navicular insertion and small insertions over the cuneiforms as well as the second to fourth metatarsals. And this is a FDL, and this is FHL. FDL, FHL crossing over mastodon of Henry. You can see here, this is typical appearance where they are crossing over here. This is concerned with normal, and you can see the how beautifully the medial aspect. You can see the medial malleolar region. This is the TP, FDL, FHL is there. FHL always will be seen behind the, you can see the talar, this is os trigonal areas where it will be FHL will be seen over here. Those three tendons we have to look at in sagittal images. What are the abnormal things can occur with medial tendon? Medial, we can go for tear. This is classical appearance of tibialis posterior tendon tear with tenosynovitis. You can see it will be seen be adjacent to the medial malleolar region. This is classical appearance. You can see the large tear in the medial malleolar region adjacent to it. Tibialis posterior tendon has gone for tear. And you can see the rheumatoid arthritis patient with the typical appearance of bony tubercle projections from the posterior aspect of the, it is medial malleolus, and you can see it is gone for continuous irritation and the tear of the tibialis posterior. And medial malleolar fracture patient which has gone for stabilization with a small screw. The screw has loosened, it is projecting outside, producing mass effect over the tendon, continuously irritating it, producing changes. This is classical appearance of post-surgical denudation of the, and this is loosening of the screw producing the changes. And especially when younger age group, when the tibialis posterior tendon or medial aspect of the joint is showing signal changes or pain, we have to carefully look for what is happening with the navicular. This is classical appearance of type 3 navicular, where you can see the navicular is a cornuate appearance, very large, where it will go for signal changes. You can see the continuous irritation of the tibialis posterior tendon with the signal changes, and this is classical appearance of type 3 accessory navicular. This is type 2 accessory navicular, where you can see the large unfused ossicle, and it is producing continuous changes over here, and you can see the bright signals. This is type 2 navicular producing tibialis posterior tendon tear. And this is FHL, the second, you can see the FHL, it is tenosynovitis, tenosing stenosynovitis. Whenever we are seeing septations, this is septations within the FHL, and you can see the tenosynovitis. This is classical features of tubercular etiology. Whenever we are suspecting tubercular etiology, fine septations, loculations, and rice bodies. If you are carefully seeing, small rice bodies will be seen along the synovial thickening. They are all very classical features of tubercular stenosing stenosynovitis. It is occurring in the FHL tendon. And coming to normal, this is extensor anterior tendon. So you can see the anterior compartment. This is TA, EHL, EDL, and this is peroneus tertius. There are 4 tendons are there. Abnormal, you can see the tendon. This is tibialis anterior has gone for tear with intrasubstance bright signals, and you can see the EDL. You can see the EDL has gone. You can EHL has gone for tear, and you can see here. You can see the EHL it gone for tear, and you can see the sagittal image beautifully demonstrating the EHL has gone for tear and intrasubstance bright signals. It is the EDL. You can see the EDL has gone for tear with intrasubstance bright signals. Coming to very important areas, this is ligaments. Ligaments, lateral ligaments, medial ligaments. Lateral ligaments are divided into high and low ligaments. High ankle ligaments are anterior tibiofibular, posterior tibiofibular, and between these syndesmotic ligaments. And low ankle ligaments are anterior talofibular, posterior talofibular, and calcaneofibular ligament. How to identify all these ligaments? We will start with axial sections. This is tibia fibula. Between this, what we are seeing is the small, flimsy, low signal areas. What we are seeing is the syndesmotic ligaments. This is high ankle ligament. Whenever it is injured, means there will be widening of the joint space will be there, and it will be of a very severe type of injury. And when I am going down, and if I am seeing the tibial profound, what I am seeing is the anterior tibiofibular. You can see the anterior tibiofibular and the posterior tibiofibular. So these 3 high ankle ligaments I have shown you. One is the syndesmotic ligament. What you are seeing is the flimsy low signal structure. When I am going down, I am seeing the tibial profound. You can see the classical anterior tibiofibular, posterior tibiofibular. So how to look high ankle ligaments? When I am going down, we have to carefully look this boomerang shaped appearance of the lateral malleolar region. Whenever we are seeing boomerang shaped appearance of the lateral malleolus, means we have gone well down. We are going to see the low ankle ligament. They are very important ligament. This is anterior talofibular, ATFL. This is the one commonest thing to go for rupture. This is the one commonest. This is low ankle, and you can see the posterior talofibular. So this is posterior talofibular, this is anterior talofibular. Still I am going down. If I am carefully seeing this is peroneus tendon. Along the inner side of peroneus tendon, calcaneofibular ligament. This is calcaneum, and this is peroneus, and this is a calcaneoperoneal ligament. You can see the calcaneofibular ligament. You can see the attachment site over here. You can see typically, so it will be seen between peroneal tendon and calcaneum. This is calcaneofibular ligament. So 3 high ankle ligaments, 3 low ankle ligaments. So low ankle ligament, boomerang shaped appearance of the classical boomerang shaped appearance of the fibula lateral malleolus, anterior talofibular, posterior talofibular, still coming down between the peroneal tendons and calcaneum. This is calcaneofibular ligament. So this is 3 low ankle ligaments where we have to look, and we have to identify how the abnormalities can occur. Now we are going to see the abnormal high ankle ligament. You can see the intraosseous ligament rupture, syndesmotic ligament rupture, and you can see the widening of the joint space, complete obliteration of the flimsy low signal band and meroedema. And when I am coming down also, you can see the complete rupture of syndesmotic ligaments. This is high ankle ligament injury. And the next high ankle is anterior tibiofibular. You can see along with the bony fragment, complete rupture. This is anterior tibiofibular high ankle ligament injury. And this is low ankle. You can see the anterior talofibular totally gone. To demonstrate this anterior low ankle, I have shown this. This is a normal anterior talofibular, and you can see the complete rupture of the anterior talofibular ligament. This is classically where we have to look anterior talofibular ligament. This is another case. You can see the complete rupture. You can see the boomerang-shaped appearance of the lateral malleolus from his total rupture, and you can see the soft tissue edema also. This is a classical case of complete rupture of the anterior talofibular ligament. Here, all ligaments have gone for injury. This is anterior tibiofibular. You can see seeing the tibial profound. You can see the partial rupture, and you can see the calcaneofibular ligament has gone unthread of. This is low signal is not seen between peroneal tendon and calcaneum, and you can see the anterior talofibular rupture. So anterior talofibular, anterior tibiofibular, calcaneofibular. It is high as well as low ankle ligamental injuries. Lateral complex have gone. So we have studied lateral ligamental. Coming to the medial ligament, it is called as deltoid ligament. Deltoid ligament is having two important fibers: superficial fibers, deep fibers. What are the deep fibers? Deep fibers will have two bands: anterior band, posterior band. Posterior band is very important. It is anterior tibiotalar, posterior tibiotalar. The posterior band is very important. And how we have to look all these things, I will show in next slices. And the superficial fibers, there are three fibers. Anteriorly from the tibia to navicular, it is called as tibio-navicular, and posteriorly tibia to calcaneum, it is called as tibio-calcaneal. Then the tibial spring ligament, where it will come attached to the spring ligament. How to see these ligaments? Please carefully look for this medial end of tibia, and this is posterior band of deltoid ligament, deep fibers. Same thing we can see over here. You can see the deep fibers of deltoid ligament, posterior band, which is very thick. So this is tibia. This is tibia, and you can see the talus. This is the deep fibers of deltoid. This is the superficial fibers of deltoid ligament. And you can see the deep fibers nicely seen. It is a thick band. Normal striations will be seen. Whenever there will be injury, we may not able to see these structures. It will be totally gone. This is a central band, so it is called as tibial spring ligament. The spring ligament will be seen over here. This is tibialis posterior tendon. So we have to look carefully. Look this aspect. This is the tibia. This is the talus. This is deep fibers. This is the superficial fibers. This is the axial. This is the anterior band, flimsy band, and posterior band is very important, deep fibers. This is the tibiotalar component of the deltoid ligament. Tibiotalar component. This is tibial spring ligament. If I am coming anterior, this is posterior, so it is coming as a tibio-calcaneal. When I am coming more anteriorly, this is a tibio-navicular. So superficial will have three structures: anterior to posterior, and this is deep. We are having only over thick posterior. This is very important. We have to look for deep as well as superficial fibers. This is concerned with the normal medial ligament. Abnormal medial ligament usually seen with the fractures. You can see there is a fracture of the talus, complete rupture of deep fibers. You can see the deep fibers of the deltoid totally gone. For normal, I have shown over here. You can see the normal deep fibers. It is a tibiotalar ligament. It is totally gone, and it is showing the bright signals. Always we have to carefully look. This is another case. You can see the complete rupture of the tibiotalar ligament of the deep fibers. You can see the superficial fibers also gone. This is the normal one for comparison I have shown. Spring ligament. What is this spring ligament? It is calcaneo-navicular ligamental complex. There are three important ligaments. One is a supromedial component, medial plantar oblique and inferior plantar oblique. Always one important thing, please carefully remember this supromedial band. How to identify this spring ligament? They are the ligament of mid-foot anchor between the calcaneum to navicular, and please carefully look for this navicular bone. The medial tendon, we know this is tibialis posterior, this is FDL, this is FHL, and this is the spring ligament. Between the navicular and the TP, there will be a low signal structure. This structure is very much essential. This is nothing but supromedial band of the spring ligament. Whenever there is injured, means it will become bright signals. Always we have to carefully look to it. This is what you are seeing is the tibial spring ligament, and this is the main spring ligament. Between the tibialis posterior tendon and the navicular, what you are seeing is the spring ligament. So this is the things we have to carefully look. Then the Lisfranc ligament. What is this Lisfranc ligament? Lisfranc ligament is the main stabilizer of entire midfoot. we have to see between the medial malleolus and the second metatarsal, what we are seeing is the tendon. You can say typical Lisfranc ligament is there. There are two components. One is plantar component, other one is dorsal component. This plantar component is very much essential. Whenever it is injured, you can see the displacement. Second to fourth metatarsals will be dislocated. This is typical appearance of Lisfranc ligamental injuries. And the inflammatory conditions, sinus tarsi and plantar fascia. Plantar fascia, the normal anatomy is there are three bands. One is lateral band, central band, medial band. Lateral band will attach to the classical appearance attaching to the fifth metatarsal. And you can see the typical appearance of the plantar fascia. What you are seeing is the plantar fascia normal. And when I am coming down more anteriorly, we can able to see the sagittal also nicely. The central band will go and the lateral band will be also seen. Whenever plantar fasciitis, we will have significant inflammatory changes will be there. The fluid collection will be seen over here. And you can see the thickness will get increased and calcaneal spur can occur and marrow changes can occur. This is classical appearance of plantar fascia, where you can see the edema as well as tear, and you can see the signal changes, and you can see the calcaneal spur is also. That is the classical cases of plantar fasciitis. Sinus tarsi, where it is a space between the talus as well as calcaneum. We can see the space, it is nothing but filled with the fat. Two important ligaments, one is a cervical ligament, other one is interosseous ligament. So these are the things we have to look, and multiple small neural fibers can occur. Whenever there is fracture of talus or calcaneum, it will go for narrowing of the sinus tarsi. So it will go for sinus tarsi syndrome, where the patient will have midfoot pain, and this is the things we have to look into. This is the sinus tarsi, this is the interosseous ligament, and these are the cervical ligaments. It will be filled with the fat. Whenever there is fracture, you can see the talar fracture completely obliterating the sinus tarsi. You can see there is a bright signal is replaced by low signal areas, complete obliteration of the sinus tarsi. Classical cause of talar fracture presenting a sinus tarsi syndrome. Here calcaneal fracture, you can see the calcaneal fracture completely obliterating the sinus tarsi. So sinus tarsi commonly associated with the fractures of either talus or calcaneum. Three important structures: interosseous ligament, cervical ligament, multiple neural fibers within the fat. Whenever it is damaged by fractures, it will go for continuous pain because of neural irritations. Anterior impingement may be because of osteophyte or because of synovial lesions. Posterior impingement will be commonly seen with os trigonum. You can see the os trigonum surrounding bursitis. Usually it will produce a compression effect over the FHL tendon. So continuous posterior pain will be there. This is a classical case of os trigonum syndrome. Sometimes neoplasms can occur. This is a case of osteosarcoma originating from the talus, projecting posteriorly, compressing over the FHL, producing posterior impingement syndrome. Last area, this is neural abnormalities, especially tarsal tunnel syndrome, Martin's neuroma, sural neuropathy, Baxter's neuropathy. These are the four conditions whenever we should report, we should carefully remember. What is Martin neuroma? First of all, it is a misnomer. It is not at all neuroma. It is nothing but entrapment of plantar digital nerve. Because of that excessive perineural fibrosis, you can see the normal nerves, interdigital nerve will be seen like this. Because of entrapment at web spaces, it will produce significant perineural fibrosis, and you can see this little bit involved. This is classical case. This is early formation of the Martin neuroma. This is a misnomer. It is not a neuroma. It is nothing but perineural fibrosis because of a plantar digital internal entrapment, and adjacent bursitis can occur. This is another case. Classically, how we have to look. It is below this interdigital bursa. We will see it. This is a typical area where it will form. It is perineural fibrosis. It is not a neuroma at all. Tarsal tunnel anatomy. Carefully look for these three structures. This is tibialis posterior, TP, FDL, FHL. This FDL and FHL surrounded by, there is you can see a classical, and this is a flexor retinaculum. So between these two important structures, this is FDL, this is FHL, there is a flexor retinaculum, and what we are seeing is the tarsal tunnel. It is having two important structures. One is vessels, other one is nerve. Two veins will be there, two arteries will be there, branches, and one nerve, and you can see the posterior tibial nerve, and posterior tibial nerve will go down, and you can see it will divide into medial as well as lateral plantar nerve, and from the lateral plantar nerve, the first branch is inferior calcaneal nerve, that is called as Baxter's nerve. You can see how the branches are coming. So what is flexor retinaculum, which is formed between FDL and FHL? There will be a flexor retinaculum surrounding it. So the tarsal tunnel is formed. Important structures are vessels as well as nerve. And this is we have to carefully look the tibial nerve over here. This is very classical site. You can see the division of the nerve. What is tarsal? You can see the neuroma can occur. You can see the sonoma, the classical string of bead appearance coming from posterior tibial nerve, and the typical appearance antennae A is classically forming the central low signal, marginal braid signals. It is classically string of bead appearance of sonoma, and you can see the ganglion cyst can occur. It will produce a compression over the, so between, you can see the FDL and FHL. Between that, the classical location, ganglion cyst, see the nerve is compressed and displaced anteriorly. Nicely, you can see the tip of nerve, we can see over here. And sometimes rupture of tendon will produce bursa, it will produce mass effect. This is a classical location where tarsal tunnel syndrome occur. What is Baxter's neuropathy? For that, the anatomy is very important. This is posterior tibial nerve, which divides into medial plantar nerve and lateral plantar nerve. The first branch of lateral plantar nerve is inferior calcaneal nerve, otherwise called as Baxter's nerve. Baxter's nerve, whenever it is going for compression, exactly where the plantar fascia is thickened means it will produce atrophy of this important muscle. This muscle is abductor digiti minimi. This will be seen over here. You can see the abductor, AB duct, abductor digiti minimi. This is abductor hallucis, abductor digiti minimi, abductor hallucis, and it will go for subtle braid signal. It will mimic like plantar fascia. We have to look into it. We have to look for atrophy of the muscle. This is very important. If you are seeing at least 1 or 2 cases per month, we can all plantar fasciitis or not plantar fasciitis. Whenever plantar fasciitis is there, please ask the patient having pain on the lateral aspect. If the patient is having pain on the lateral aspect and atrophy of the abductor digiti minimi means it is Baxter's neuropathy. When it is winding around, where it will be compressed. So this atrophy is very important. We have to carefully look for abductor digiti minimi atrophy. It is Baxter's neuropathy. And the sural neuropathy, it is the lateral aspect, where sural nerve means it is associated with short saphenous vein, and the lateral aspect of the tendo-Achilles, if it is going for thickening and braid signals, it is very important. Tarsal coalition, it may be of 2 types. Is it of calcaneonavicular coalition or calcaneocuboid? Calcaneonavicular coalition will go for derangement of the subtalar joint, meroedema, joints are formed, and osteophytes. You can see the classical. It will go for flat foot, continuous pain will be there. These things we have to look. This is classical appearance of calcaneotalar coalition. It may be of osseous or fibrous. And one important thing here, it will go for severe involvement of the medial facet of subtalar joint, osteophytes. So the tibialis posterior tendon will be compressed over here. So 2 types of navicular commonly we have to look, and this is calcaneonavicular and calcaneocuboid. And other signs are talar beak sign. You can see the talar beak sign, and anteater sign, where you can see the sustentaculum talar will be more of anteater sign, reverse anteater sign, and all these signs we have to carefully look whenever we are seeing for. And you can see how much the medial facet of subtalar joint is degenerated whenever it is going for its tarsal coalition. It will produce mass effect over the tibialis posterior and FDL tendons. These tendons are compressed, so it will manifest as severe pain in the medial aspect. Whenever young patient less than 20-30 years coming as flat medial aspect of pain, please carefully think over this condition. It is because of tarsal coalition. Thank you very much. Last 1 case I can demonstrate as well.